My name is Paul Elbers from Amsterdam, and I have the great honor to give you the last talk. So I hope you are still a bit excited. Did you learn a lot today? Yeah? So my talk is about how to consolidate this in your unit, because that may not be that easy. And we have learned now from Dr. Smet here that if you use ultrasound, everybody dies. But you don't want to do that, right? So I hope this will work though. Yeah, there we go. So what you need to do, and this is my disclosure, is come to the Netherlands because we can do a consolidation course. But there are also other courses. Now that I'm here, I might as well tell you about it. And the good thing about it is that you can practice in your own hospital because we give feedback through the internet for 40 ultrasounds. I had the honor to write a review on 10 reasons why to do lung ultrasound last year, and we have learned a lot about this today because I think lung ultrasound will really be your friend, and lots of courses, not this one, but lots of other courses focus primarily on the heart. But I think it's essential as an intensivist to focus on both because ultrasound can actually be better than a CT scan, but we've seen this over and over again throughout the day. And this is the Blue protocol rewritten in a certain way that it makes it easier to use because, as Mike de Smet already told you, it's very difficult to think in these kind of chances. So if you look at all these circles, then it makes you kind of aware that there's no absolute things in lung ultrasound. Whenever you find a certain pattern, it can also be something else. But you have to keep in mind that while you do not have certainty, you can have a reasonable chance of a certain diagnosis compatible with a certain blue pattern. So you've noticed that there are a lot of abbreviations in ultrasound medicine, and that's because everybody designs their own course. It's not really necessary, and luckily Daniel Lichtenstein also created the Society Against Acronyms, and I support this society especially because you only need to remember one abbreviation, which is intensive care ultrasound. You know this by now, and it consists, but it's one of the many consolidation courses, I should be honest, right? But I'm just going to tell you how we did it for the Netherlands. So we have 22 views that are compulsory, and with these views, if you have this structured approach, you can integrate this into your patient data management system, and if you then simplify it to dichotomous questions, you can make your diagnosis. And if you do this 40 times, then we consider you to be an expert. But if you have no expert in your hospital now, it's very difficult to learn because now you have learned the basics, but then you go home to your patients and the first view you make, you see a lot of snow or you can't even find the heart and there's nobody there to help you. So what are you going to do? And there are a lot of societies, for example, this comes from the European Society, and they've come up with all these fancy abbreviations what you can learn. And they have multi-page documents on how this should be delivered. But in the end, you'll be there with your patients, and you need to feel confident on what you're doing. So do we need proof on this? Well, I think it's very obvious that ultrasound will help you, but we have proof now. It improves your diagnostic accuracy, and that has long been known, but recently in the Lancet, it has even been shown that it improves the time to diagnosis. So this is the Danish group of Erik Slot, that is a pioneer in ultrasound. So ultrasound is there to stay, I think, and I think the new generation of intensivists will be trained from the beginning in it. And interestingly, this is a Chinese study, so it might not be valid for the Western world, but ultrasound actually decreased ICU stay. So this makes it very economically feasible to get a lot of ultrasound machines in your unit if this is really true. Okay, so we have to be careful, but as I said, it's not an all or nothing game because we can also have situations that even after pneumonectomy, you have artifacts mimicking pleural sliding. So you have to be very careful, and you have to understand the physiology. And also you have to be careful that if you only do ultrasound, that you forget about the other ways to, for example, insert lines. And that can be very problematic in very urgent situations, or if your ultrasound machine is broken. So, what can you do? A very common problem when you start to introduce ultrasound in your unit is that you're going to get a lot of discussions with cardiologists and radiologists. So I know that the first talk of this morning was also a bit about this, but I can show you some real-life examples of what happened in our hospitals. And I have to remind you first that in our hospital, before we introduced ultrasound in the intensive care unit, we talked to the cardiologists and we said to them, okay, we can help you and we will not look at the cardiac valves. So we'll leave that to you, but you have to let us do the cardiac ultrasound for simple things, right? So this patient came to us, a 50-year-old male, had a myocardial infarction, ventricular fibrillation, advanced life support. He came out of it, of course, and he got drug-eluting stents, and there was some trouble weaning from the ventilator and inopressors. So our very senior intensivist, he is now 64 years of age, and he was very keen on learning ultrasound. This was one of our first ultrasounds. So this is an excellent PLEPS point. So we see a lot of pleural effusion and lung atelectasis. And then we're looking at the heart, and we see a reasonable contracting ventricle. Filling looks okay. Does anyone see what the problem is? Because we didn't see the problem, but that was clearly a mistake. But if you look carefully, there's a problem with the mitral valve. So the coaptation is not correct, and there was a papillary muscle rupture. So luckily for us, and also especially for the discussion with the cardiologist, one day before, the cardiologist also made an ultrasound examination, and in retrospect, it was also visible there. So that closed the discussion, but it shows you that it's very important that if you do not find something on your ultrasound examination that can explain the clinical situation, you still have to proceed with your normal routine and ask, of course, for a cardiology ultrasound. This patient eventually did well after a lot of complications. Well, I actually spoke to him 3 weeks ago and he said, I had another heart attack, so it's a bit of a routine for him now. So it was the 3rd time. But he seems pretty happy about it. So this is another patient. She did not do well in the end, but we didn't know that yet. And she had cancer, related deep venous thrombosis, ischemic stroke, no thrombolysis because of bleeding risk, and infralateral myocardial infarction. She was admitted to our intermediate care, and we found, upon screening the heart, we found a mass in the right atrium. Then we got into a discussion, why did we even do the ultrasound? It's a routine thing for us, but now we needed to decide what to do with this incidental finding. So there was really a lot of discussion. We discussed about 4 or 5 hours in multidisciplinary meetings, and in the end it was decided it was probably a thrombus, but she was refused surgery. She was found to be too frail. And we put in a caval vein filter, and she was eventually discharged to rehab, but she passed away. So now the problem is, how do you deal with the situations? Because on the one hand, you can have incidental findings. On the other hand, you can have diagnosis that you can miss. And the important thing is that you need to feel confident, and by definition, you will be capable as an intensivist. You'll be more capable to do your ultrasound in the context of intensive care medicine. But on the other hand, you need to talk to your radiologist and cardiologist to really define the area you're going to look at. Because you are uniquely qualified, however, other people think you're not. For example, the cardiologists, they put out a statement in which their point of view is that you should refer every patient with abnormal ultrasound findings to them. And obviously the critical care community does not agree, because if you have a clear finding that explains how the patient is doing, it doesn't really make sense to then burden the already overloaded system of cardiology. And I think we finally have a good argument, because it was recently published that lung ultrasound will be introduced as a new tool for the cardiologists. So they're actually learning from us now instead of the other way around. So you have to ask yourself, having done this basic course, are you now good enough to be confident with your diagnosis, and in terms of responsibility, but also in terms of litigations? So how many studies should you do to be reasonably competent? Well, generally people agree that it should be around 20 or 30. So in the UK it's now 50, in Holland we do 40 just to be safe, but studies prove that 30 fully supervised TTEs should be enough to be reasonably confident. It can also be graphically displayed, and it's the same in virtually every study. 30 seems to be a magic number. So for the incidental findings, it's important to know, should I inform my patients? Sometimes, and maybe this is a specific Dutch thing, there's a law in which that states that the patient sometimes has a right not to know things. At least you should think about these kind of things, and you should really talk to your cardiologist and radiologist. But on the other hand, it would be a great waste of resources if you don't use ultrasound, because using ultrasound in the management of patients and not doing it could be considered inexcusable. So I think you should get structured certification just to circumvent the associated problems. And you need your support by your local team. So you have to clearly define locally what your competence is. So talk to them and, for example, say, I'm not looking at valves. If I suspect a problem that I cannot explain, I will come talk to you. And it's very important that everybody is on the same page there. So a final comment on whether you should store your images. So it is very reasonable not to store these images if you don't want to get into any problem, right? Because then you can always say it's just an extension of my physical examination and nobody really knew what I did or what I didn't see. But I would strongly advise against it, even though in the States it's a popular way of doing it because the litigation culture. But it's very disadvantageous in terms of trying to learn, because if you review your own images and if you make the images with having in mind that other people can view them, you pay much more attention to making them. And it's also coming to other professions. So in America, there's respiratory therapists, and as we show now that they actually can be taught much faster than doctors, because within 12 scans, they're fully competent in lung ultrasound. So I think the next frontier will be that nurses will be doing your ultrasound for you. And if your nurses are going to do it, you should certainly be able to do it yourself. So of course, but I'm very much biased. We recommend certification, and I think you should do it in Holland. But you can also do it anywhere else. But I think it's very important to be confident in ultrasound. And if you consolidate with confidence, then you can be the best for your patients. Thank you for joining this course.